owning the patient doesn't really matter that much. I think that understanding the importance of a multidisciplinary approach is the key to success here. I mean, in my institution, none of us have a lot of ego in the sense that, it's my patient and I just send it to you when the patients need chemotherapy. I think understanding that men with metastatic hormone-sensitive disease may require urology, may need radiation oncology, and will need a medical oncologist. So I think that it is fair to say that, for instance, I'll give you an example of the importance of actually partnering as a team between med-onc, GU, and radiation oncology. If you have metastatic low-volume disease and you happen to have your primary prostate in place, the standard of care, in my opinion, today, with the STAMPEDE data, with other pieces of data from HORAD, and so forth, would indicate that you want to put that patient on your best systemic therapy. And at this stage of the game, in my opinion, would be suppression of testosterone in addition to abiraterone acetate and prednisone, and you should consider treating their primary tumor. So STAMPEDE clearly has suggested that men with low-volume metastatic disease who get intensified with ADT and ABI may in fact have survival improvement, when you get radiation therapy to a primary tumor. That data was actually looking at ADT, chemo, and radiation against ADT and chemo. But since we believe ADT and chemo, tends to be very similar in nature, if I'm allowed to use that expression, compared with ADT and ABI for that patient population, I think that the consideration of radiation therapy for those men with low volume disease is key. The field is changing drastically. There is a lot of movement in trying to actually even subset patients with low volume disease into what we call oligometastatic disease. Oligo, obviously from the Latin root, small or little, so I think the bigger question is, how do we define oligometastatic disease? Is it 1 lesion, 2 lesions, 3 lesions? Those patients do have metastatic disease, but we may be able to render them free of disease if we intensify their therapy. So now we're talking about maybe the potential of actually getting intensification of your systemic therapy, radiating your primary tumor if you have in place, and for that matter, even considering radiation therapy approaches to sites of disease that are outside the pelvic or in the bony structures. I think that for castration-resistant disease, I think that it is an oncological-driven approach, obviously. I recognize that the market has changed, and there's a lot of interest from some specialty groups, especially within the urology practices in America, to use oral therapy such as ABI, ENSA, maybe darolutamide if it gets approved. But the reality of it is, I think that, again, I continue to believe in the principle of working as a team for them to maximize the outcome of our patients. So if you do that, if a urology group is treating someone with CRPC, at some given time, that patient may require chemotherapy, and that partnership with a medical oncologist will be key. Okay, so regardless of how you treat the patient or who treats the patient, once again, I think the importance is, even in the setting of metastatic castration-resistant prostate cancer, you do want to have your patients exposed to all the life-prolonging treatments that we have. There are many changes in the field. We talk about genomics right now, not only just counseling you for your family history and so forth. For instance, this case, the patient had a history of colorectal cancer. So the question is there potentially a genomic change in your tumor that we can tap for therapeutic purposes? There's a lot of movement with DNA repair deficiency in men with prostate cancer. There are new immuno-oncology agents approved for patients even with prostate cancer, but who happen to have macrosatellite unstable tumors. So I think the field is changing drastically. Perhaps the biggest change in my mind is for patients who have low volume metastatic disease. And the movement of many of these oral agents is getting pushed all the way to the radiation setting with primary radiation, with salvage radiation therapy. And we are obviously pioneers in neoadjuvant concepts where we actually put patients on oral therapy, prior to surgery, or even do surgery for high-risk patients and try to minimize the risk of recurrence by adding, these novel oral therapies.